So I sort of annually give a little talk about screening for prostate cancer. These, I think, are the 5 things urologists need to do it better. It's too much to go into during a short talk such as this. So I'm just going to highlight a few things that I think are really important and possibly underappreciated by many urologists. And the first is early in life PSA. I think we've got to get our PCPs and ourselves, if we're capable of contacting the patients, to do early in life PSA measurements because this really implies if you have a slightly elevated PSA, which incidentally is above 0.9 in your mid-40s, those are the men who have the highest risk for the later developing clinically significant prostate cancer. And that was even true in the PLCO cancer screening trial, and these were men who were aged 55 to 60. You can see how the 12-year or 12-and-a-half-year risk of prostate cancer, significant prostate cancer, is occurring in proportion to their baseline PSA at the entry into the study. Fortunately, this concept of early in life PSA is being studied in a European trial called the PROBASE study. There really are no good data on it yet because it's very early in the phase, but we have to keep an eye out for it. The second thing I want to talk about is family history. And I know we also talk about family history, but boy, this is a study from Sweden of something on the order of 6 or 7 million men. And you can see if you had no family history of prostate cancer, the proportion of men who were diagnosed with prostate cancer at age 50 or 50. So the average population is in red. But look over here. If you had one first-degree relative diagnosed before the age of 60, that guy's occurrence of prostate cancer was about 10 years earlier than the average guy's occurrence of prostate cancer. So we really, if we want to get the killer cancers, I think we really have to emphasize screening the right patients sooner. Who are the right patients? Okay, we've heard this alphabet soup of high penetrance genes that certainly are putting a man at increased risk for prostate cancer. As I'll show you later, it really only accounts for 2 or 3 or 4% of all prostate cancers that we diagnose in the United States. I think we have to turn our attention to these lowly penetrant germline SNPs, single nucleotide polymorphisms. And fortunately, over the last several years, they've been studied more and more. And I'll just review a few of these studies here. I like this Venn diagram. This is the overlapping proportion of men in one study that said they had a positive family history for prostate cancer. The proportion who are in the highest quartile of this polygenomic risk score, shown there, a much bigger circle, meaning there were more men involved. And the highly penetrant genes that I showed you on that pie chart earlier, only 1.5% of the population. But here's the strength of it. If you said you had a positive family history of prostate cancer, you're right. Your rate ratio, the incidence and mortality of prostate cancer are elevated. You can see that here. If you have a high polygenomic risk score, very similar elevations. But go down here. If a guy told you he has no family history of prostate cancer, he really has hardly any significant reduction in his chances of either being diagnosed or dying of prostate cancer. But look at this. If he has a low polygenomic risk score, he cuts his chance of being diagnosed in half and his chance of dying by about 2/3. It's a very powerful, very objective tool. We studied it in PLCO and REDUCE and the prostate cancer prevention trial, and it works. It always enhances the diagnosis of prostate cancer. But here are some of the more recent studies. This is from the UK Biobank, and you can see by decile of genomic risk score what the rate ratio of prostate cancer was, and you can see in the highest decile a dramatically increased risk. Another way of displaying how these polygenomic risk scores compare to these highly penetrant genes. So if you had any of those highly penetrant genes, that explained in the UK Biobank only 1.7% of the prostate cancers, and you can see what the hazard ratio was. But look, if you were in the highest quartile of this polygenomic risk score, that itself explained 2.2% of the with a higher hazard ratio. And you can see if you said any genomic risk score above the median, you can see the proportion of patients you would identify as being at high risk, how that compares to the proportion of patients who said they had a positive family history. And moreover, the half of the patients whose polygenomic risk score is in the lower half, or the lowest quartile, you maybe don't even need to screen, because look at their odds ratio for getting a significant prostate cancer. The one limitation to some of these, but I'm going to show you one that's being developed in the VA, is that in the UK Biobank, it did not predict fatal or aggressive prostate cancer. Now that's not true of all these polygenomic risk scores, and I'll show you that right here. These data just come out, done in the Million Veteran Program, the VA hospital, evaluating about 500,000 men with this polygenomic risk score, comparing the top 20th percentile to the lowest 20th percentile. The hazard rate for fatal prostate cancer was 4.5 times increased. And you can see how knowledge of this polygenomic risk score adds overall to the area under the curve, or the concordance index, which is essentially the same thing, over and above race, ethnicity, family history, and other clinical variables. So keep your eye out for this. This is coming. The VA is launching a very large study assessing this prospectively in much more detail. I want to present a hodgepodge of new things that come out in the last year. This one caught my eye. We're all getting MRIs, and maybe more and more of us are looking at MRI calculated PSA density. I don't think anybody knows what the right PSA density cut point should be. This study looked at a positive MRI where you probably don't even need to consider it, but maybe you should use a PSA density cut point if your patient has a negative MRI or a PIRADS 3 lesion. And you can see if you use a cut point of 0.1, the proportion of cancers that you would detect, or if it was 0.15 or 0.2, just showing, and it makes good intuitive sense that we should adjust what we consider to be the PSA density cut point on the basis of other clinical data. That makes perfect sense. In this next segment, I'm just going to remind you the NCCN guidelines talk about either getting an MRI or a biomarker. The 6 biomarkers that they recommend are shown here. This paper just came out in European Urology, which was a meta-analysis of essentially all the published data on biomarkers in this space. And so you can see PCA3, 4K, PHI, Select, EXO, and the Michigan test. And you can see the sensitivities, specificity, positive predictive value, and negative predictive values. I like this paper. Why? I'm a big fan of 4K. Why? It has the highest negative predictive value. And this is this is too small for me to read. I forget what that shows. But here's the summary of this meta-analysis. Conclusion. Regarding the detection of clinically significant prostate cancer, 4K had the highest diagnostic performance among commercial liquid biomarkers. So they're not all the same. At least, now there could be publication bias, let's be honest. 4K's been around for about 10 years. A lot of good people writing a lot about 4K, so maybe that influenced these outcomes. But it's always been my go-to biomarker for what that's worth. This approach is being evaluated also in a study looking at PSA, if abnormal, of 4K. In certain 4K strata, you would then get a prostate MRI and then proceed to prostate biopsy. So there's good prospective studies being done to analyze that. Here to me was a disappointing report that came out regarding the Stockholm 3 test, which is sort of a combination of the 4K score and a polygenomic risk score. And I'm a little bit surprised. If you use the Stockholm test alone at their recommended cut point of 11, you only avoid 20% of the biopsies. Most of the other biomarkers avoid 30 to 40% of the biopsies. On the other hand, in using that cut point, you're going to miss 8% of the clinically significant cancers. That's too high. The 4K score, you only miss 3 or 4% of the clinically significant cancers. And you can see if you add these other variables to create your cut point, your proportion of missed cancers gets worse and worse, and not better and better. Sure, you avoid more and more biopsies, but you're missing more and more of the place. So I was a little bit surprised because I was keeping my eye on that as one of the most exciting things. This was the 15-year outcome of the PROTECT trial. A couple of important things from my point of view. Remember, the PROTECT trial randomized men to surgery, radiation, or what they called active monitoring. Guess what? About 60-some% of the patients within the first 15 years got either prostatectomy or radiation therapy. And after 15 years, it's true, there's no statistically significant death from prostate cancer or overall mortality. Look at this, alive with metastatic disease, there's twice as many in the active, who started out in the active monitoring group as men who were treated with prostatectomy or radiotherapy. And similarly, clinical progression, again, three times as high, still alive. And, let's see, I lost a slide here. I'll remind you that 3 or 4 years ago, the authors, Freddie Hamdy, actually did a comparison of just active monitoring versus the combined arms of actively treated patients. So they combined the prostatectomy and the radiation-treated patients and compared them to the active monitoring patients. Guess what? Statistically improved mortality in the patients who were actively treated if you combine both treatment modalities rather than active monitoring, even though 60% of the patients later on got treated. So we're wasting, I think this PROTECT study is not as good a study as it's been touted. Just another personal opinion. Now, in addition to clinical data, there's all these genomic classifiers: Decipher, Oncotype, Prolaris. I happen to be working with a company called Prostate Genomics. This is a Swedish company. This was developed off biopsy material from men who were treated conservatively in Sweden for the last 10 to 15 years. It uses the expression profiles of 3 embryonic cancer stem cell genes, plus PSA, plus T-stage, plus biopsy Gleason score. And you can see it categorizes into 10-year prostate cancer-specific mortality. The only deaths were in the high-risk group. And you can see 10-year metastasis. Most of the metastasis were in the high-risk group. Some were in the low and intermediate group. Because these are cancer stem cell genes, they're seem to be clonally expressed throughout the prostate. The correlation of a biopsy prostatype score to a radical prostatectomy prostatype score, whether it's the index tumor or some other tumor you happen to find during radical prostatectomy, is 0.83, which is really, really very high, much higher than what's been published for some of the other markers. And finally, some urologists like the idea of predicting adverse pathology for newly diagnosed prostate cancer. Adverse pathology, incidentally, is either Gleason 4+3 in the specimen and or pathological T3 or worse. You can see the area under the curve is 0.88. So keep an eye out for this. These are all Swedish data. We're doing a very large study in the United States, the results of which should be out very soon. Another nice paper this year was in the New England Journal of Medicine. Paul Pinsky, Howard Parnes, everybody knows them. They're at NCI. They did PLCO, PCPT, SELECT, all the prostate cancer-related trials that were funded by NCI. These are, tend to be nihilists with regard to PSA-based screening, but this was a positive article published in the New England Journal of Medicine. And notice that in their synthesis of the data, they recommended, if your PSA test is positive, to confirm it, which we should all do, that the next maneuver should be a triage test, which is basically a biomarker, not an MRI. And you can see the MRI comes later in the schema. Here's a little bit of bad news. The average number of days of life gained by PSA-based screening for prostate cancer was like 34. And you can see it wasn't even statistically significant in this other analysis. There'll never be a big benefit there because remember, only 2.5% to 3% of men die of prostate cancer. Here was a very nice paper published in the European Urology looking at the worldwide screening studies and examining digital rectal exam, PSA, or both for both positive predictive value and overall cancer detection rate. And I will give you the conclusion. DRA exhibits notably low diagnostic value, and it could be potentially omitted from PSA-based screening, and I think we're all getting there. Patients are going to love not having a DRE. I'm going to love not doing a DRE. Well, I already love not doing a DRE. But some have said if the patient has symptoms, you should still do a DRE. Anyway, final thing, another bit of good news. Okay, we're using a lot more active surveillance. For some reason, this was published in the Annals of Surgery, not in the Urology journal. They looked at malpractice claims regarding active surveillance, mostly of prostate. There were a few thyroids in there. But in any event, all of the verdicts were for the physicians, as long as they had, you could probably read it better than me, good documentation that they discussed the pros and cons. So thank you very much for your attention. These are my summary statements. Thank you.